Good morning, everyone. We will begin shortly. Okay, welcome everyone. My name is Sarah Minirad, and I am the new PBRN coordinator with DO-Touch.NET. Thank you for joining us for this month's episode. Before we begin, I just have some housekeeping rules for the webinar. Please add your name and your location to the chat so that all the participants can see who's in the webinar. If you have registered for CME, you need to add your name to the chat so that we can verify your attendance and you can receive your CME credit. Additionally, you will have a physician attestation form, which was sent to you this morning via email, and an evaluation survey that will be sent to you this afternoon that you will need to complete to receive your credit. So the Let's Talk About OMM Research Planning Committee has no conflicts of interest to disclose. If you have any technical issues during this webinar, please send me a message through the chat and I will assist you. If you have any questions or comments during his presentation, please feel free to type them into the chat, and please feel free to discuss with each other about those comments or questions as well. After the presentation, we will have time for discussion and questions. If you would like to speak during the discussion, please raise your hand and I will unmute your microphone. We ask that you briefly introduce yourself, and please feel free to turn on your camera if you would like. When discussion, please limit microphone time to 3 minutes to allow time for everyone who wants to participate in the discussion. We will provide you notifications of time to keep everyone on track. Please keep in mind that this webinar is recorded and will be added to our website and to our YouTube channel so that others can see it. Also, we will have a discussion forum on our website, and please look in your email for notification that the webinar has been posted so you can contribute to the discussion there as well. So please help me welcome Dr. Brooks, who will be speaking about the 2 journal articles that are linked in the chat. Dr. Brooks received his Doctor of Osteopathy degree from the Chicago College of Osteopathic Medicine in 1980. He has served in private practice as a consultant, as an assistant professor of clinical surgery, and as an associate professor of OMM. He is currently an active research member with AT-Still Research Institute and a member of the DO-Touch.NET Executive Committee. Dr. Brooks, I'm going to stop sharing so that you can, and then the floor is yours. We can't hear you, Dr. Brooks. You'll need to unmute.
Thank you, Sarah. Can you hear me now?
Yes, sir.
Okay. Now I gotta find my share screen.
Dr. Brooks, you should be able to click share screen at the bottom. There you go.
Can you
Okay.
see it now?
Yep, we can see it.
Can you still see it?
Yes, sir.
Okay. Can you still see it? Can you see the big slide
Yes, sir.
now? Okay, great. Okay. So as Sarah mentioned, I'm in private practice and I currently work part-time for the Anderson Research Institute.
Dr. Brooks, we are seeing the presenter mode on your
Okay.
slides. I think if you swap displays.
How's that?
Perfect. Thank you.
Okay,
Thank you, Jane.
but I've got to get you guys in a different space. Just hold on a second. Sorry. That's not working. Okay. We can't bring that down to swap displays again.
Dr. Brooks, can you go back? Yeah, click that button. And then at the top, there should be a button that says use as slideshow.
Yeah, unfortunately, I can't get to the top. I don't know how on my computer. Let me do
Okay.
that. Just a
We
second.
might just be able to use it just as the PowerPoint, just like that, rather than a slideshow.
We had it just a minute ago. Boy. Over here. So,
2 clicks ago, you had it.
how is that working out, folks? Does
Perfect.
that work?
Yes.
Okay. Okay, so I want to acknowledge the consultant I had to help me prepare for this. Aaron Ashbeck is a biostatistician and research assistant for the University of Arizona Arthritis Center. I have no financial disclosures. I'm not talking about drugs. I am publishing a book, and there may be some indirect references to that. So we're going to do four things today. We're going to have some background discussion because I've been following this question for over 40 years. We're going to talk about 2 papers, and then we'll have hopefully some time for questions and discussion. Fundamental challenges for osteopathic manipulative medicine going forward in the future boil down to these 3 things. Does it make sense? How well does it work? And how safe is it? And obviously, we're discussing the last question today. Well, apparently it's not perfectly safe. There's a very prominent public figure who passed away after chiropractic cervical manipulation a few years ago. This was highly publicized. I've spent about a quarter of my career working for major MD orthopedic surgery groups, first in Minnesota and then at the University of Arizona. And I can attest to the fact that this concern about stroke from cervical manipulation is the major psychological barrier in the MD world for considering the use of manipulative medicine. So I'm going to share with you a case that is relevant to this conversation. that I had over 40 years ago. It was one of the more dramatic cases in my experience. And so a little perspective is that the first case report of stroke associated with cervical manipulation came out in 1947. In 1974, there were only 12 reported cases, and I began medical school in 1975 and practiced exclusively of osteopathic manipulative medicine in 1981. As medical students, we had anxiety about this issue, but it was pretty much not spoken about. It was very rare, reported, and we had this, what proved to be mistaken idea that old folks were particularly vulnerable to this because we'd probably break something and lacerate something and so on and so forth. So in my first year of practice, when I was being mentored by Robert Fulford, who was one of the renowned figures in the field of cranial osteopathic manipulative medicine, and who was known for his use of and development of the percussion vibrator technique, so not high velocity manipulation. And I was totally enamored with his work and his technique. And as a naive young physician, thought if I just could be like Bob, I'd be on top of the world as a doctor. So one day, a 76-year-old woman walked into my clinic and said she had a headache, wanted my help. And I said, well, how long have you had your headache? Well, since I was 16 years old. Well, you can imagine what went through my head. I was, of course, thinking, and you expect me to do something about this after 60 years? But I kept my professional demeanor and I said, well, why are you coming to see me now? And she said, well, things have been getting worse and I'm taking more and more Fiorinol, which for those of you who are not familiar with it is a combination drug that has 4 medications in it, one of which is a narcotic. I said, well, okay, I'll do what I can to help. So I got out my trusty percussion vibrator and started working on her and did what I knew at the time was cranial osteopathy. And I could feel the fascias moving under my hand, monitoring hand, and I didn't really have a good sense of what I was doing, but I thought I wasn't doing much because it felt like she was really loose. So I worked on her 2 or 3 times and it was just empirical. But I thought, I've done what I know how to do according to what Dr. Fulford's taught me. Let's see if she can get off her medicine. So I asked her to cut her medicine in half, and she came back in a week or 2 and said her headaches had really flared and that didn't work. So I said, well, I'm sorry, I've used the best techniques I know, and I don't think I can help you. Well, she broke down in tears and she tapped into my compassionate, want to take care of my grandmother mode of thinking. And I thought, what else can I do? Well, I could revert to what I was taught at the Chicago College of Osteopathic Medicine, which was high velocity manipulation to the spine. And then I thought, oh my God, that's going to be really, really risky because she's 76 years old and I could stroke her out. But my emotions overcame my intellectual anxiety. And so I examined her using the techniques I'd learned in medical school. And I found that there were a lot of dysfunctions that I had not perceived using the examination technique that Dr. Fulford taught me. So I proceeded to use high velocity manipulation on her spine, including her neck. And I saw her back 2 or 3 times of using that approach and thought that I'd actually made some progress. So I asked her to cut back on her medicines again. And she did. She came back in a week or 2. And how do you feel? I feel fine. Well, that really caught my attention. So I treated her some more and cut back on your medicine again. Comes back, follow up in a week or 2. I feel fine. The upshot is I got her off all her medicine using high velocity manipulation to her neck. I ran into her a year and a half later on an airplane. She'd had no recurrence of her headache and was not using any medicine. So this was instructive to me on many levels, and we'll come back to this later in the discussion. So early in my career, in the early 80s, there was a family physician, or back then it was a general practitioner, in Tucson, where I lived and worked, who had a patient who manipulated their neck and they had a stroke. And it was pretty well known in the DO community that this had happened. And so this got my antenna up, and I started looking at the literature back in the early 80s, and I followed this. One of the messages in the 20th century was that most of these incidents were associated with chiropractors who not only precipitated some neurological signs and symptoms, but whose cure-all was more manipulation. So these people got not 1, but 2 interventions and then ended up having strokes. By 1993, when I was a faculty member in orthopedic surgery at the university, and I had cared for an awful lot of my colleagues and their families, I was asked to help present a grand rounds in the Department of Neurology on this subject. And by that time, it was understood that the mechanism was not breaking off osteophytes, but that arterial dissection occurred, thrombosis and embolization. And I remember the conversation vividly because there was a lot of hostility in the audience about the use of manipulative medicine. And the bottom line was that even if there was the slightest risk of this serious complication, this should never be done until it was proven that this was really a effective and meaningful form of intervention. In contrast to that, because of my experience in that community, there were some people who defended me and the use of this technique simply because of their personal experience. So, as further background on this, Dr. Degenhardt asked me a few years ago to do a literature review on adverse effects from manual medicine, which I did for about the years spanning 99 to 2019. And while these are my definitions, this is one of the things that's come out of that experience, were the definitions of what an adverse event is, which is any temporal association or correlation with some sort of medical intervention that's, at least at first take, seems unfavorable. That's not the same as an adverse effect, because there's a difference between an association and causation. So an adverse effect is considered to be an adverse event where there's a causal link between the 2 phenomena. And that in turn is broken down into side effects and complications. Side effects would be those that are self-limiting, complications are not self-limiting. But in the world of osteopathic manipulative medicine, we also recognize what we call a treatment reaction, where this, again, there's a consideration of a causal link. And it may be unpleasant initially, but that it's part of a beneficial process in the long run. And this is not dissimilar to things that are recognized in the world of psychodynamics, where, to put it simply, sometimes people have to get worse before they get better. So this literature review I did revealed some big themes. First of all, the research in the 21st century is extremely cultural. It kind of boils down to the MDs versus the chiropractors. And there isn't much input from the osteopathic community at all. We, Dr. Degenhardt and Jane and I published a paper a couple of years ago that began to add to that literature. One of the other major insights is that unlike the 76-year-old that I was so worried about, there's almost no report of anybody over the age of 45 that's experienced this. So having done this literature review, I've selected these two papers because I think they capture the back and forth of this conversation, even though they're both written by allopathic communities. So most of us are familiar with this so-called evidence-based pyramid. And I want to point out that near the bottom, case report, case series, narrative reviews, expert opinions, and editorials, that's considered very low evidence. And the meta-analysis and systematic review, which is what one of the papers the paper by Church et al. Is a systematic review with a meta-analysis embedded in it. Whereas the Kennel paper is a case series and expert opinion. So at first take, one would think that the Church paper is much more weighty than the Kennel paper. Well, we're going to touch on some of these things, but the whole point of doing, being appreciative of the different qualities and pros and cons of these different kinds of interventions that we just reviewed is to try to minimize bias. And ultimately, we do that as a community. None of us walk around free of bias. And so our attempts to address bias is a community effort. And we're going to touch on a few of these things, but for those of you, this was all pretty new to me just a few years ago, that I've just been learning about as I've participated in journal clubs at the University of Arizona. There are these multiple sets of criteria that have been developed by the scientific community to adjudicate different types of studies. And we'll mention especially the last four of these in the discussion about these papers. And they're pretty extensive, and they are continually refined. So the first paper we're going to talk about is the one by Church et al. And we're going to review, first of all, where it was published, secondly, who the authors were, and then we'll go through the paper, the background, materials and methods, results, and the conclusions. So this is this is the 21st century, and it's a digital world, and we now have all kinds of publications, open access publications, etc., that didn't exist 20 years ago. So Curious Journal of Medical Science is a newfangled thing. It was established by an emeritus professor of neurosurgery at Stanford. And I think it's notable that he's a neurosurgeon because he's a proceduralist. And we need to remember that osteopathic manipulative medicine and more broadly manual medicine are procedures. there's a fundamental different set of standards we need to be held to than drugs. And Dr. Adler's idea is sort of to go back to the beginning, which is that what's more precise, the big thing in nowadays is precision medicine. What's more precise than, talking with your patient in great detail, examining your patient in great detail, really coming to appreciate person as best you can as a whole unique person, which sounds like osteopathic philosophy. And that he hopes that his journal will be a repository of case studies, case series that might ultimately then, using the techniques of so-called big data, be merged in a way that can provide quantitative analysis. So I think this and journals similar to this should be on our radar screen, because we've been critiqued for a century about all we have is anecdotal reports. And this might be a portal for us to start adding to the literature. One of the other differences about this journal is that they've developed what they call a scholarly impact quotient. So they do peer review, but I get the impression that it's not quite as rigorous as the New England Journal or the Annals of Internal Medicine, et cetera, because then they rely on post-publication commentary to continue to vet these publications. So here's an example, because this is what was one of the post-publication peer reviews for the paper that we're talking about. And it was published by 2 chiropractors. And they basically applaud the conclusion of Church et al. And certainly, from my point of view, there's a great risk of bias here. And they also then suggest that this research continue because additional studies have been done and so forth. Well, one of the problems when I tried to use this was that unless people published a commentary, so they give a rating, and the ratings on this paper were pretty darn good, between 8 and 9 on a scale of 10 in terms of quality and so forth. But they don't tell you who gave the ratings. And so, having reviewed this literature over 20 years, I'm very concerned that the ratings of 8 or 9 were pretty highly biased by the chiropractic community. So now we'll talk about the other thing that I want to mention is that Dr. Church is a neurosurgeon. He's an academic neurosurgeon. He has over 50 publications, and this came out of the Department of Neurosurgery at Penn State Medical Center. So this, was presumably a weighty group of people from a weighty institution that published this. So the fundamental question of this paper is, does chiropractic cervical manipulation cause cervical artery? So it's almost always vertebral artery, but sometimes it's carotid artery, dissection, and consequent stroke. And they did 4 things. They used 4 sets of these criteria. First of all, for the literature review, they used the PRISMA criteria. For their meta-analysis, they used the Moose criteria. For adjudication of causality, because these events are so rare, and there have not been any prospective randomized controlled trials, and there probably never will be, unless Jeff Bezos decides to fund it. They use what's called the Bradford-Hill criteria. And then, in an even more all-encompassing sense, they use the grade criteria. And we'll briefly touch on what all 4 of these are. So the PRISMA criteria are this process of how you do a literature search and then select the studies that you're actually going to review, and potentially do a meta-analysis on. So they did that. Then, once they decided to do a meta-analysis, they used the Moose criteria. And I'm not going to read through all this because it's voluminous, but that's my point. This is just a visual for you, but it's to raise your awareness that this is the kind of adjudication that needs to go into doing the meta-analysis. So there's just a whole ton of questions that need to be addressed. So you start with the title, the abstract, the introduction, quite a few search strategy criteria. Statistical methods, of course, have to be defined in great detail. The results have to meet a wide variety of criteria. You have to be conscious of, where you're getting your data from, whether it's a subgroup analysis, etc. You have to be able to fully describe the uncertainty of your findings. So just a p-value isn't good enough anymore. You've got to have confidence intervals and so on and so forth. And finally, you have to really scrutinize the types of study, and, there's just lots of different questions and criteria that need to be met in order to meet the Moose guidelines for inclusion in a meta-analysis. So supposedly they did that in this paper. And what they came up with was 5 retrospective studies. They actually started with 6, but one of them was kind of superseded by another one. So it boiled down to 5 studies they thought were worthy of meta-analysis. And 4 of them were really small numbers of people. And the comparators were people who had strokes. These were all retrospective studies that were thought to be due to cervical artery dissection versus strokes from other causes. And the Cassidy study basically looked at that question, but they also then looked at how many people presented to primary care physicians as opposed to chiropractors and what the outcomes were. And the use of the word neck pain as a confounder is problematic. Erin Ashbeck really took issue with that because from her perspective, neck pain was an indicator. I do think that there's a sense in which it's a confounder, but it's a challenging word to use in this setting. I think one of the things that was most evident, which we'll get to in a minute, was that in a sense, the results were between these 5 studies were very heterogeneous. So while there was legitimate reason to include these 5 studies, the results were very heterogeneous, and that weakens a meta-analysis. So the other background piece of information is that they classified the studies according to yet another set of criteria that have been developed by learned bodies according to what's called evidence classification. And there's class 1, class 2, class 3, class 4. Excuse me. And basically, class 1 studies are the best and class 4 are considered to be the weakest. And as you can see, just again, visually, without reading through all this, there are a lot of criteria that have to be, judgments need to be made about. So in their paper, they had 2 papers that were class 2 and 3 that were class 3. They did in their discussion discuss the possible biases in these classes. And they did a separate analysis of just the class 2 studies, because one of the problems with meta-analysis is when you have different levels of evidence, the weaker evidence might arguably alter the stronger evidence. So in some conversations with colleagues, some people will hang their hat on one really good study as opposed to a meta-analysis where there's an amalgamation of different qualities or different levels of evidence. So they did a separate analysis just of the two class 2 studies, but the problem with that is you might as well just read the two studies, because the amalgamation is there's so few participants that the value of of merging those two is pretty marginal. So I think this basically repeats prior slide. I apologize for that. So now we're going to talk about their meta-analysis, and this was their discussion that the combined data suggests an association between dissection and chiropractic care. And heterogeneity, though there was considerable heterogeneity in meta-analysis refers to the variation in studies, but the outcomes between studies. So if we look at the actual visual here, you'll see that and I don't know how to use a pointer on this, I apologize, but the Cassidy study, the confidence intervals were fairly small. But if you look at all 5 of them, they're kind of all over the map in terms of how far apart they're spread from one another. And the conclusions that they based on were based down on at the bottom in the diamond, because that's when they merged all the data, that's what they got. But what they don't emphasize in the paper is that, with the exception of the Dietrich study, which had just, and maybe to some extent the Cassidy study, just a smidgen of confidence interval on the not associated side, the overwhelming evidence was of an association. So we're going to talk a little bit about how we adjudicate cause, because that's really the bottom line. That's the big word here is, does cervical manipulation cause strokes? Well, randomized controlled trials are considered to be the gold standard in the adjudication of causes, because in theory, you can control or account for all the confounders. That is consciousness that there may be multiple causal factors. So that's also known as internal validity. With all the worshiping of randomized controlled trials, though, we often forget that there are limitations to them. Sometimes you can't do them because of ethical considerations. And even in the best of circumstances, there's always the possibility of latent variables. In other words, of confounders that we're not conscious of yet. The universe is a pretty big place. Humanity is a pretty big group. I just looked at some COVID stuff and comparing it to the Spanish flu. There were only 1.5 billion people on the planet in 1918 when the Spanish flu epidemic happened. And now we have 5 times that number. So finding all the variables is always an open question. And then when we do randomized controlled trials, we usually have to narrow down the population. So how applicable it is to a broader population is problematic. And then with the kind of topic we're talking about today, which are considered to be rare events, and again, my literature review shows that there are other potentially serious complications from manual medicine, but they're even rarer than these. Epidural hematomas, or an occasional massive disc rupture or something like that. I mean, they are so extremely rarely reported. So doing a randomized controlled trial that would capture these things is almost impossible, unless, again, Jeff Bezos decides to give us a couple $1 billion to study it for the next 50 years. So one of the things that's been done in this literature to address this concern is to use the Bradford-Hill criteria. And this was published way back in 1965. And basically, he sets out 8 criteria which ought to be met in order to firmly state that X causes Y. And I put temporal relationship in red bold here because basically, except for one other paper that used this criteria, all the judgments of causality in this literature have been because of temporal relationships. And certainly that's true in the second paper we're going to talk about, the Kennel paper. The tight temporal relationship seems to be very, very compelling evidence. So they also use the grade criteria. And this comes from the British Medical Journal. It's supposed to be a transparent framework for developing and presenting summaries of evidence and provides a systematic approach for making clinical practice recommendations. So this is the end of the line in terms of what the authoritative bodies say we should and shouldn't do. And they use all these different criteria, study design, or they look at all these questions, study design, risk bias, inconsistency, indirect, et cetera, et cetera, et cetera. So there's a whole lot of things to take into account. But I also want to highlight the first phraseology. A final grade designation was achieved by consensus after discussions involving all study authors as recommended by the grade guidelines. So what did Church et al. Conclude? And it's embedded in the title, no evidence of causation. No evidence of causation. But the absence of evidence is not proof of evidence. And oh, by the way, a paper that they didn't cite, which was done in January of 2008, or published in 2008, notably by an undergraduate college student, but with a whole lot of other apparently weighty authors. They used the same criteria. Now, they didn't have the same data to adjudicate because it was 10 years earlier, but they used the same criteria and they came out with a very different conclusion, that there was weak to moderately strong evidence to support causation between cervical manipulative treatment and vertebral artery dissection and associated stroke. Well, this should highlight how subjective this process is. The Hill criteria say a temporal relationship is necessary but not sufficient to establish causation. In this case, the onset of, this was the Church, the language from the Church paper. It said temporal relationship is necessary but not sufficient to establish causation. In this case, the onset of symptoms following cervical manipulation is variable and often delayed. Yeah, but they forgot to say that sometimes it's not delayed. So we're going to switch now to the Kennel paper because I think this reflects more of the current consensus in the allopathic world. And frankly, it reflects more my opinion. I think this is much more rigorously reasoned, and the language is much more rigorous than in the Church paper. They concluded that they pointed out that there had been a randomized controlled trial that showed manipulation was effective, but no more so than physical therapy exercises, which were equally effective. There was reason to believe that the incidence of this occurring is much more than reported. Notably, they changed the language from causation to association and to considering that cervical manipulation is a risk factor. So there's an important difference in language there. They also pointed out, because a lot of people who practice manipulative medicine are not fully trained and licensed physicians, that it's very vital that anyone who practices this type of care be educated about the signs and symptoms of possible cervical artery dissection, that they not manipulate someone who's presenting with any of those possible signs and symptoms, and that informed consent always be provided, always be obtained before performing these procedures. Now, I get informed consent from my patients, and I ask them, has anyone ever talked with you about the risks associated with manipulation? And it's a very, very, very rare patient who says yes. Well, certainly the major critique of this kennel paper is, well, it's just a case series. It's low evidence. And in fact, so much of the literature is just anecdote and case series. Well, I want to switch gears a little bit and talk about the concept of causation now. Words matter. There's a difference between saying something's a cause and something's an association and something's a risk. We all know the old image of the proverbial straw that breaks the camel's back. And when we do a randomized controlled trial prospectively, we're trying to isolate that final straw that breaks the camel's back. And if you watch the straw drop on the camel's back, you can say, well, that caused the camel to collapse. Well, what do you mean by cause? Did all the straw that was on the camel's back in the first place participate in the cause of the camel collapsing? But it's even worse when you got retrospective studies. Now, how do you figure out what the cause was? Because it's after the fact. Which straw broke the camel's back? So we need to be very, very careful about our use of the word cause. So let's go back to the evidence pyramid. So the other thing that in the British Medical Journal publication about the grade criteria that they're very front and center about is the use of the grade criteria is subjective. In other words, it relies on expert opinion. But if you look at this evidence pyramid, that's supposed to be really low evidence. So we kind of come full circle where we don't give a lot of weight to expert opinion. And yet, when it comes to systematic reviews, meta-analyses, and ultimately clinical practice guidelines, what do we have to rely on but expert opinion? Now, admittedly, this is where the community comes in, where all these criteria have been developed. So when it's one expert's opinion, that may not have as much weight. But I think it's really important that we be conscious of how much this is a very, very human endeavor. We grow up in grade school and high school thinking science is just about finding facts and objective reality, but it's not so simple. And in response to these concerns, there have been some other models developed to reflect the complexity. One might call these webs of evidence rather than the hierarchy of evidence. So I just thought this was important to call to people's attention so that, because certainly the kinds of studies we're trying to do through DO-Touch.NET need to be understood as having their rightful place in this web of evidence and not be dismissed as lower quality studies if you base your thinking on the so-called evidence pyramid. And here's another model that kind of reflects that complexity. So I just got these off the web, so I'm sure you guys can find stuff like this on the web if you're interested. Now, this is something I developed because, I don't know of any medical intervention that is free of risk. There are times when doing nothing is really risky. Certainly in my population with chronic pain patients who are really desperate. And I have reason to believe that some suicides occur because people have reached the end of their rope with their chronic pain. So sometimes doing nothing is not safe. But it's going to be, again, extremely hard for us to do really, really rigorous research in terms of how to truly compare these types of interventions one to another. But if we base this on the literature that exists, I think this pretty fairly represents that drugs and injections and hospitalization and surgery are qualitatively riskier. And I know I'm running out of time, so I'm going to hustle up here. I apologize. So we need, in the long run, in the fullness of time, to figure out how we can compare the risks of manual medicine to acetaminophen. Thousands of people die from liver failure, some of it self-induced, but others because of chronic pain in the United States every year alone. NSAIDs are definitely worse than that. We need to start looking into, and I know that's one of the things that we're certainly trying to do in the DO-Touch program, is comparing high velocity techniques to other mobilization techniques. Well, going back to my 76-year-old patient, my strong opinion is there's a time and place for everything. There's a time when high velocity works and other things don't. So how do we adjudicate that? How do we discover what the predispositions are for injury? And one of the things that's fairly clear is, below age 45. After that, your risk goes way down. I tell all my patients that if anybody develops acute onset probably unilateral head and neck pain, we stop right there and we get a vascular workup before we do anything else. Certainly, if there had been very significant cervical trauma in any kind of proximity to that, you need to be cautious. Hypermobility syndromes, while they've not been rigorously linked to this risk, there's certainly reason to be concerned. And perhaps more fundamentally, we've got to really understand what the heck we're doing when we manipulate the spine. Because I'm not convinced at all that chiropractic mechanical diagnosis bears any resemblance to osteopathic. And even within the osteopathic world, there's a great deal of potential room for improvement. So here are a few of my take-home messages. I think that words really matter, that using the words associated or that cervical manipulation can be a trigger or risk factor or causal factor are much more intellectually integritous than just using the word cause. When I was at the University of Arizona, the neuroradiologists there said that they saw this happen about once a year in a town of 750,000 people back then, so it's probably more common than we think. Know when not to do it. I get informed consent, both written and permission at the time I'm going to do that. And as I said before, we need to consider mechanical diagnosis in great detail. We certainly need more and better research. And so I'm putting in a plug here for participating in DO-Touch.NET. And in the long run, so for any of the younger members of this conversation, not only do we need participants in DO-Touch.NET, but the registry has to be something that the whole world knows about. Because let's be frank about it, the likelihood that if you have a patient where this happens, that you're going to report it publicly, especially in the United States with the medical legal system being what it is almost zero. The reporting is going to have to come from someone other than the practitioner. I know that Dr. Degenhardt's working very hard on standardization of diagnostic techniques and another aspect of the Manipulative Medicine Center at the Andrew Taylor Stowe Research Institute. I think we need a paradigm shift away from the alignment models, and there's a growing literature on regional interdependence. So the complexity of the mechanical diagnosis, which I'm trying to address in my book, is another thing that I think needs to be addressed in the future. So sorry, I've taken a little more time than I'd hoped, but I guess we got just a couple, 3 minutes left for questions.
May I ask a question?
Sure.
Dr. Brooks, thank you for a very interesting presentation, especially about what is proof. But I'm a bit not sure what the word is in English. Maybe I could put it like this. Imagine I'm one of your patients and you esteem that you must manipulate me to a cervical manipulation, high velocity. Could you give me an example how you would ask for my consent? Because I'm wondering what is the implication of nocebo. I'm not sure how you would say that.
Yeah, you're concerned about the nocebo effect. I understand what you're
Yes.
saying. Well, you know, I just have to take that as it is, because I sit down before I even examine a patient and go through with them what I consider to be the relative risk, and I discuss this literature about cervical manipulation. I point out a profound difference in the way I evaluate the cervical spine from the chiropractor. We talk about the relative risk, and I ask them to sign an informed consent before I even examine them at the first visit. And then at a later time, as I'm caring for them, if I think high velocity manipulation to the neck is indicated, I ask them for permission at that time. And in my practice, it usually doesn't happen in the first couple of visits that I would even address that. So hopefully by that time, they've developed some confidence in me. And only the rarest patient, demurs and doesn't want me to do that. And so there probably is a heightened anxiety about it, but I've spent a lot of time in care with the patient. And, at least in my practice, it works out pretty well.
Okay, thank you very much.
Dr. Brooks, Dr. Dean has a question for you. Dr. Dean, you're going to have to unmute on your end.
Okay, thanks. Dr. Brooks, I was just wondering, up here at Michigan State in the HVLA course, we teach about how the chiropractic HVLA uses more of a rotational force and it's less localized, as opposed to the DOs who use a more localized approach with, at least at Michigan State, more side bending with their thrust. And I just wondered if there's anything in the literature, obviously not necessarily chiropractic versus DO, but is anybody looking at like the DO model versus chiropractic and incidence rate?
Well, I'm going to be addressing that in my book, but fundamentally, I think the alignment model that still permeates a lot of osteopathic thinking is profoundly flawed. I think we have to learn how to do a very thorough three-dimensional mechanical evaluation of the whole spine, and with a consciousness that not only what we've been taught about how the spine functions, the so-called Fryette's rules, we have to realize that the way it malfunctions may be profoundly different. So this is a theme I've been talking about for decades. And I think, at least in some places, they've kind of gotten the idea that there's a fundamental error in thinking in the musculoskeletal medicine world, which is, it's called functional anatomy, for starters. That we think we can describe static phenomena and understand dynamic phenomena. And I don't think that's correct. And then similarly, even if we fully understand, if we have God's insight into how the spine functions, I don't think that tells us how it potentially malfunctions. And so it comes back to this simplicity. If you don't take the time to thoroughly evaluate the motion characteristics in 3 dimensions, and in the neck, you can evaluate it from anterior to posterior as well as posterior to anterior, that you are at risk of not actually discovering the dysfunction and treating it, thus a false negative finding, thus an ineffective treatment, and B, arguably over-treating something that's essentially a false positive and irritating something. So my experience with chiropractor patients, and it's purely my experience, I've had patients come in who've been treated by chiropractors over and over and over again, and their spines turn in the transverse plane as if they were in The Exorcist. They could practically swivel around, and yet there's no, and they can't side bend at all. They're just absolutely rigid. Okay.
Wow.
So I'm advocating a completely different approach to the spine, which comes back to the simplicity of you got to examine your patient, and you got to examine it thoroughly, and you can't have any theoretical prejudice about what you're going to find based on some rules that we teach.
Right.
And once you do that, then you have the potential, the increased potential, in theory at least, to effectively care for your patient and diminish the risk of injury.
Thank you.
Dr. Brooks, we do have a few questions in the chat, and then other questions we'll have in the discussion forum on the website, but we wanted to make sure to ask these 2 questions here. The first is from Dr. Downs, and he asks, how much of a vascular workup is necessary to have done due diligence?
Well, frankly, I'm not a vascular physician, and I would, if a patient came in to me with that, I would punt to an expert in the field, but I suspect at least whether it would be Doppler studies, and I don't know that Doppler studies are very meaningful in the vertebral system as opposed to the carotid system, but probably an MRA, magnetic resonance arteriography, if not coupled with an MRI, would be. I mean, if you're that concerned, I wouldn't cut any corners. I'd get specialized input on that. I mean, it's never come up for me in my practice to date. I think it's extremely rare. This whole idea of cervical artery dissection, whether associated with cervical manipulation or not, is a pretty rare event. I mean, it's well known to occur, but it's not your everyday event. And it's obviously very, very ominous. So if I ever had my antenna up about it, I would just stop and get help.
Thank you, Dr. Brooks. The last question is from Dr. Mallarney-Regetz, and they ask, what is the proposed mechanism by which younger patients less than 45 years old are thought to be predisposed to CAD compared to older adults?
So the bottom line here is that, again, we think that there's a mechanical trigger. It's cervical manipulation is one, but this cervical artery dissection and stroke happens in all kinds of other settings. And almost invariably, there is some sort of final straw that breaks the camel's back, some sort of mechanical trigger. They're in a car wreck. They can turn their own head and neck rapidly, and this will happen. So there's apparently a congenital or even genetic predisposition to failure of these arteries. And basically, it catches up with people in the 3rd and 4th decade of life. And then something happens that's the proverbial straw that breaks the camel's back. And this is one of the reasons that the Cassidy study and the chiropractors have been pushing back against this use of the word cause, that basically these are disasters in progress. And it so happens that some people go to chiropractors and get manipulated, and that's the straw that breaks the camel's back. A lot of people go to primary care doctors, and just with the passage of time, there's something else that's the proverbial straw that breaks the camel's back. So basically, I think the idea is that for the vulnerable population, this is going to happen. And it's going to happen in the first, 40 to 50 years. And if you're susceptible to this and you live, I mean, if you're not susceptible to this, you're going to live, past that time, barring other medical problems, without this happening. So I don't think people really know at this point, but that's what it looks like, that these are congenital or even genetic issues, and that they will manifest early in life. And if you live past that time, you probably don't have that congenital vulnerability. I hope I've answered that question satisfactorily.
Thank you, Dr. Brooks. Thank you, everyone, for attending. Any other questions we're going to have posted on the discussion forum on our website, and we'll also have this recording available on our YouTube site. So we'll actually post that on social media, an announcement that it's up, and we'll also post an email to you guys to let you know it's up. So if you have further questions, Dr. Brooks can log into the discussion forum and answer those for you. Thank you guys so much for attending. We hope you have a good day.